Hey guys, welcome to the Gate Geeks podcast. This week we're going to talk about some clinical cases and the kinds of material we'll be covering in our upcoming seminar on October 5th and 6th. See you in a sec. Hey, how's it going, guys? Hope you're all doing well. Scott in Florida, Ivo and Bill in Colorado here. We've been running through a lot of stuff, seen some interesting stuff come through the office lately. We thought we'd share a little bit about that. Hopefully you see us on our Instagram page or you've gone to our website and checked out some of this information as well. We do have an upcoming seminar, pretty much soup to nuts on what you need to do to know how to, when to prescribe orthotics, and then how to do a lot of modifications, what the indications are, that kind of stuff. And talking a lot about orthotic therapy, not necessarily, it's not set and forget, remember, it's something that should be dynamic and changing for your patients. And if it's not, then you need to look at either what your patient's doing or what you're doing.
Right. And a lot of that is going to be centered around, just general walking mechanics and running mechanics and how those two different activities play into your choices and the way in which you want to move with regards to orthotic therapy. So again, hope to see you guys all out there. And like Ivo said, today, we're just going to be talking about a couple of cases and how we might kind of make our little adjustments based on how the patient presents. So anything else you want to do or say, Ivo, before we get going?
Nope. If you're just catching the first part of this podcast, you can go to thegategeeks.com and sign up if you want to do it. The seminar's coming up in 2 weeks here, so.
Yep. And so when you hear the videos playing, some of the videos will not allow us to speak over the top of them. So when the video is done playing, we'll chime in and kind of go over our thoughts at that point. So just a little heads up on that. So without further ado, let's just start with a basic still image, shall we? Let's go with something like this. What this was one of yours, Ivo. What do you think here?
So here we go. This is a patient that came in with medial knee pain on the right-hand side. And what we want to see, everybody's doing a clinical exam on your patients. With this particular patient, when I look at people when they're laying on the table, I look at two different things. One, I put their feet straight and look at the position of their knees. And then two, I put their knees straight and look at the position of their feet. This particular patient here has what we call windswept biomechanics. And what does that mean exactly? It means his foot's turned out on the right and in on the left. So he has external tibial torsion on the right, internal tibial torsion on the left. This is most likely due to in utero changes when he was carried inside. But that means one foot is kind of pointed to the outside and one foot's pointed a little to the inside. So it's going to change the mechanics from side to side. The left side, or the internal tibial torsion side, is always going to be in relative supination, whereas the right side is always going to be in relative pronation. And then with these particular things, we always like to say that abnormalities run in threes. So, are there other things, mitigating factors that are going on? Does he have a forefoot varus or valgus? Does he have an anatomical leg length discrepancy? Is there talar torsion? Is there something else going on that we need to be looking at as well? But I wanted to put this up mostly. So one, we're looking at something like this. And this is the person that comes in and they kind of have medial arch pain on the right and they have pain on the tail of the fifth on the left-hand side. Sometimes it's just a unilateral problem, sometimes it's not. So they go to see their friendly, whoever they see, and they put them in an orthotic or they put them in a footbed. And wow, what happens is the right side gets way better because with a standard footbed with Russian-based biomechanics, we pick that foot up, put it into inversion. That creates a supinatory moment on the right side, which is over pronatory. The knee straightens out and the knee pain gets better. The problem now is when I put an orthotic under the left side because he's got internal torsion, that pushes the knee further outside the sagittal plane or further laterally. So now all of a sudden I'm going to have patellofemoral tracking problems that I didn't have before. So the right knee gets better, right short term, the original problem that they presented with, but now they present with left-sided knee pain and nobody can kind of figure out why. Sometimes they'll also get pain over the tail of the fifth, or they'll develop a peroneal tendinitis because that left side is in relative supination, and that peroneus longus's job is to create plantar flexion and eversion of that foot from mid stance to terminal stance so they can push off with high gear push off. And when that gets overused, it's going to get ticked off. So depending upon how much space they have in the rear foot or the forefoot, not space, but a range of motion that they're going to have, and what's available there is going to depend upon what their particular adaptation or accommodation or compensation pattern is going to be. So considerations, and I'll let you jump in here in just a sec, Scott.
Mm-hmm.
When you're doing this person and you're seeing them, if you're going to decide, oh, they're a candidate for orthotics, we need to give them some mechanics that they don't have, is it's going to be totally different on the right side than the left side. So the left side is going to more than likely have some sort of a valgus posting, which is the post that's going to push that forefoot over onto the first met, which is really, really good, provided they have range of motion in the first met and they can get it down. And if they don't, then you're going to force the knee to the inside and you're going to create other problems. You're going to want something that's going to control pronation probably a little bit more on the right side. So just food for thought. What are your
The other
thoughts?
thing, yeah, my thought is just by looking at this, and again, this person was not sitting on my table, so it's hard to say, but just looking at this image here, and you mentioned it earlier on when you were talking about the things that occur in threes, is it looks to me like the left leg appears a little bit longer than the right leg. To me, I see, the flag on the sock sitting a little bit more inferior on the left side than the right side. I'm looking at the tibial tubercle on the left side versus the right side looks a little bit lower. And even the superior aspect of the patella seems a little bit longer. So to me, it almost appears like this person's femur is a little bit longer than on the left side than the right side. And again, you'd want to, look at what's happening at the hips. You can't really see that from this particular image. I'd want to see what they look like in stance. I'd want to see, the mobility of their sacroiliac joint and see how things along those lines are moving. But just from this particular still image, that would be something that I would want to dive a little bit deeper into. And you mentioned that. So I agree.
Yeah, absolutely. Again, one, we're just examining, we're looking for relative symmetry. And when something's not, does that happen to occur on the symptomatic or the asymptomatic side? And then your job is to figure out, okay, so why? Why does it look like this? Or what are the possibilities? Why did the body think that was a good idea?
Mm-hmm. Perfect. So in this particular image, we're looking mainly at lower leg alignment. In this next example, let's picture that it's not going to be the same person, but let's picture the socks are off and we're looking at the feet. So that leads us into something like this. So again, when you start identifying uh, abnormalities, issues, things that maybe tell a story as to what's happening, a picture like this is worth 1,000 words in my opinion, or in my eyes. So, when I look at this, what do I typically see? This is what I'm kind of seeing here. I'm seeing that, there's a bunion. There's the hallux abductor valgus. You see a second toe longer than the first, so that's called a Morton's toe. It's hard to appreciate in this particular picture, but when you actually have the patient live, you can see that the transverse longitudinal arch is collapsed. There's a flattening of this area of the dorsum of the foot. You can see a narrowing of the heel, indicating oftentimes of a QP atrophy. The dorsum of the fourth toe has some wear or some irritation. There's some redness there appearing. And there's also, which you can't tell in this particular picture, let's say, but there is a rear foot varus based on their neutral alignment, we'll say. So, what initially looks at just a basic foot later becomes to us, I know Ivo and myself, as a way to tell a story as to what is potentially happening up the kinetic chain, whether it be maybe there is a tibial some torsion on the tibia, maybe there's some retroversion or anteversion on the femur, maybe there's a leg length, maybe there's just some weakness of the foot. Maybe there's a collapsed arch due to inability to stabilize the first ray, or some weakness of the tibialis posterior. The foot intrinsics may be not helping or assisting in stabilization of the transverse longitudinal arch. So there's a lot of different things here at play. It's not as simple as just one thing leading to all of this. There's probably multiple things leading to a foot that looks this particular way. Ivo, you have anything else to add to this?
The only other thing, and you mentioned it somewhat, you can see the narrowing of the heel from the QP atrophy, but a sure sign a lot of times that we have a weak QP, the quadratus plantae, is that third and fourth toe trying to crawl underneath the foot.
Yep.
And you can see that happening, almost got that claw or cupping motion there. And you'll notice that the yellow nail polish clashes with the red shoes on the floor. But no, that was it, yeah.
Excellent. So just to give you an idea of some of the things that you may want to try initially, and this is something that we did initially, is to deal or help address, you take the basic sock liner out of the sneaker and you do a medial wedge to help address that rear foot varus. You try to add a little bit more arch contour via the use of a scaphoid pad that is self-adherent or has an adhesive back to it that sticks right along the medial longitudinal arch. And then I added a metatarsal pad to help with the transverse longitudinal arch. This is just something to help stabilize. The other thing that I did add to this particular person was a toe spacer to help with the alignment of the toes to help mitigate some of that stress that was being placed on the medial aspect of the hallux and that bunion, trying to allow for a better push-off position. Thoughts on this, Ivo? Is this something you've ever done, or would you have done something different?
Yeah, definitely. Just as far as tricks of the trade, things you can do, if you don't have a scaphoid pad laying around, you can take a metatarsal pad, and they are sided generally. There's a right and a left. And you can cut the metatarsal pad in half and make your own scaphoid pad. Or if you have a simple grinder in the office, you can create one which is actually skived to their arch specs, which is pretty nice. And we'll be talking about a lot of that at the seminar and actually having students do that kind of stuff. The other thing, whenever you have any kind of a rear foot abnormalities, you want to make sure that that heel cup is plenty deep, because remember that calcaneus is supposed to evert as soon as it hits the ground, right? So we get that plantar flexion, adduction, and eversion of the talar dome, but that's going to cause that calcaneus to evert out about 4 to 6 degrees. And if we don't have a deep enough heel cup, that heel will slide right over the side, and then we'll develop some peripheral blistering on that outside, or they'll start to wear away a little bit on the outside of the shoe. Also with met pads, super important, as you're seeing in the front there. Great for transverse arch, particularly people that have a weakened transverse head of the adductor hallucis, which she could because she had that abductor hallux abductor valgus going on. We remember that when we can't anchor that first ray down to the ground, that the adductor is going to pull the big toe west. When it's anchored, it actually helps to form the transverse and the longitudinal arches. Well, you want that met pad just behind the metatarsal heads. Mm-hmm. If it's not, you're going to create a dorsal moment on the distal aspect of the metatarsal. Whenever we move the metatarsal head dorsally and posterior, we change the axis of rotation, and you're going to limit how much dorsiflexion is available to that joint. I can't tell you how many people that we see in our offices that come in with metatarsal pads that were either put on at the factory or put on backwards or sideways or incorrectly, that are under those met heads that are actually creating the problem. And just replacing that and fixing it, it wasn't the orthotic was wrong. There wasn't a problem with the prescription. It was just not done in the right manner. And it's really hard for the lab to guess, unless you're sending petagraphs in, and even then it can be a problem. It's really hard for the lab to figure that out. So metatarsal pads is something that you should have the orthotic sent to you disassembled, okay, as far as the forefoot aspect of it, and they leave a little bit of space under the shell so that you can put that pad in exactly the right place, because a couple millimeters is going to make the difference for that patient's comfort and also compliance using the device. And that's another thing that we'll spend a bunch of time doing. We'll put them in the wrong way and make you walk around in them, and then we'll have them in the right way and have you walk around with them so you can actually see what that's supposed to be like.
Yep. Agree. All right, let's add a video. Let's do a couple of videos here. Let me make this go away, and let's add a video.
We saw the other day with the bilateral, but largely left-sided plantar fascial pain at the medial calcaneal facet. Common finding you're going to see with these individuals is they're going to have a shorter leg on the opposite side. We can see, looking at his feet here, nice and even. He's got an anatomical short right tib on this side. If we bring his legs down, we can see, looking at the leg lengths, that he's a shade longer on the left side. A lot of times on the longer side, the foot has to work a lot more. Greater amount of pronation means a greater amount of forefoot abduction, which is going to tension the plantar fascia when you get pain right here at that medial calcaneal facet.
So in terms of how you would address this, Ivo, to me, one of the big things that I notice with people that come in and present with true leg length deformities is that, they're oftentimes given a heel lift, right? Quote unquote heel lift. The problem with a heel lift is if it's truly just a heel lift, you're basically putting the ankle into a plantar flex position. and you're almost hiking the hip up as opposed to truly lifting the entire leg up. So when I make lifts, I tend to make them as full length as possible. Obviously, depending on the discrepancy, you may not be able to get as much in the forefoot as you can in the rear foot. So that's something that I've done over the years, is I've beveled it or kind of layered it in a certain way so that the midfoot to rear foot can accept a little bit more than the forefoot. But you got to lift the entire leg up unless you're trying to shorten the Achilles tendon for a given pathology or reason, an equinus foot, let's say, maybe. If there is a true leg length, you got to go the entire length of the foot. Anything to add to that?
Absolutely. We use full length sole lifts. We cut them right to size in the office. We've got different, we use 75 durometer EVA. We've got different thicknesses and stuff, and we can grind to anything in between to make that work. So, absolutely. And also, when you're picking up just the heel, you're putting the foot in a relatively beginning of a supinated posture. Remember, supination is plantar flexion, inversion, adduction, whereas pronation is going to be dorsiflexion, eversion, and abduction. And that was one of the points of this video. This kid had a long leg on the left-hand side. He was getting pain from plantar fascial tugging right at the medial calcaneal facet. And if the leg is longer, generally speaking, this is a soft rule, right? But people have a tendency to pronate longer on the long leg side and supinate more on the shorter leg side. So if that calcaneus has to evert farther, that forefoot has to abduct more, that places more torque on the plantar fascia, causing a little bit of a tug on the insertion, which is going to create pain. So when we treat something like this, in addition to using a lift on the opposite side, if we're using an orthotic or something, some kind of device or footbed, which is providing adequate support for them, we make sure that the arch is underneath the sustentaculum tali. So you really don't want to be pushing up on the navicular. You're just going to roll around the mid-tarsal joint. We really want it under the sus, which is going to invert the rear foot. Some podorthic friends of mine that I've worked with for years always used to hammer that into the head, as you can control the rear foot to control the rest of the foot. So you do that first, and then you do everything else. So I'm not a huge forefoot poster unless it's a forefoot valgus and occasionally
An uncompensated
toe extension, right, or uncompensated forefoot varus, right, where you have to bring the ground up to them. But with the idea that they're doing the exercises that they need, our end game, and I think we've talked about this before, Scott, is to get the person out of orthotics. I don't want you to have to wear something in your shoe for the rest of your life. So we give you the orthotics so that you can get through the event, whatever you're doing for now, and then do your exercises, do your therapies that you need, and then we continue to pull correction out so you don't need it anymore. And that's the ideal end game, at least what we're using it here. So we're not like everybody needs orthotics. We're like, sometimes people need a little extra help, or sometimes people aren't willing to do or don't have the time to do their homework. So as a result of that, you have to help them out a little bit.
Yeah, agree. All right, let's go to the next one.
Hey, so people a lot of times wonder what a true forefoot varus looks like. With this particular individual here, we're looking at him laying down in this particular area. We're going to make sure the calcaneus is straight. We're going to push up on the fifth in this area here to lock the joint out. And if we look at it right from the top here, you can see that his forefoot, you're going to have to come down just a little bit. The forefoot is very, very inverted with respect to the rear foot, and he just doesn't really have much plantar flexion available to him. That's the same story on this side as well. Lock out the fifth coming down. Not much motion. With the forefoot supinatus, generally we have some flexibility in this first ray. That's also going to be complicated by the amount of varum that he has. So normally we're looking for about 4 to 6 degrees of varum, and he's got between 10 and 12. So that's what a forefoot varus looks like. Thanks.
What I like to do also, that's great. That was a great one, Ivo. What I like to do is if I think there's a forefoot varus or potentially a forefoot supinatus, I'll get them in stance. I'll get them into that neutral. I'll have them invert their rear foot and see if they can keep their big toe on the ground, right? If they can't, I call it LMI of 0. An old podorthist and podiatrist taught me that term, LMI of 0, which is lateral malleolar index of 0. It's when your lateral malleolus lines up with the lateral border of your foot, right? So when that is aligned, what happens to the forefoot? So in stance, you get them into that position. If their forefoot pops off the ground and isn't able to be manually pushed down to the ground due to whatever reason, right? It's probably a forefoot varus. However, if you're able to push that big toe down to the ground with some manual pressure, you're thinking more of a soft tissue restriction, more of a supinatus. And that's something that I like to do, and how I like to kind of do it, as well as, like Ivo showed in the video, in the non-weight bearing position, getting a good idea for the feel of that medial column.
Yeah, absolutely. We do it all day long. And then with those individuals, obviously, you're going to have to support them differently. If you use a standard type of orthotic or footbed device, which is just going to basically jack up the rear foot as they come through mid stance to terminal stance and pre swing, their forefoot is actually going to go, their big toe will go all the way down to the ground. The problem is it's going to do so at the expense of spinning that lower extremity in medially and collapsing that knee medially, which a lot of times will cause patellofemoral issues and things like that. You can, with some of these hard deformities, particularly a rigid forefoot varus, you can a lot of times make some headway with mobilizations, self-mobilizations at home, exercise, that kind of stuff with patients. So depending upon the degree of plasticity is there will depend upon the degree of correction. This is one of the few cases when we have somebody like this that we will use a forefoot post. A lot of times for this, I'll use a Morton's toe type extension, which is just going to pick up the big toe, but it also depends, do they have motion in their second, third, and fourth as well? If the entire forefoot is in inversion and relatively rigid, then I'm going to use like a big triangle that's going to be thicker on the medial side under the big toe and thin to nothing under the little toe. Whereas if it's just the big toe, I'm just going to support the big toe and to allow those other toes to come back. Remember, whenever you stick anything under the sesamoids, though, you're going to move that axis of rotation of that first MTP dorsally and posteriorly. When you do that, you're going to limit how much dorsiflexion is going to occur. So when you're going to do that with a patient, you need to make sure they're in some sort of a rockered running shoe as they're coming forward. Otherwise, you're going to create binding over time at that first metatarsophalangeal joint, and then eventually they'll form a little exostosis or a little bone in that area there. And I think Scott's way is great. We can also, you can stand people down, or stand them up, I should say, and watch what their foot does and what their rear foot does. In other words, are they compensated totally in the rear foot because they have that range of motion available, or is the knee going medially? Mm-hmm. For people that are just don't want to use orthotics or can't wear an orthotic or something like that, a lot of times what we'll do, like if they're weightlifters, is we'll take a magazine or a couple magazines, stack them underneath just the first met as they're doing their squats or whatever exercise that they're doing to help to hold them up. That whole knees in, knees out, have your feet straight ahead thing is kind of not so great with the whole weightlifting world. I have a lot of conversations with competitive and non-competitive weightlifters. It's like, it's all about your knee positioning. Worry less about what your feet are doing and worry more about where your feet are. And then if you do have some kind of a leg length discrepancy and it's tibial, we have to make sure that we're compensating for that by placing something underneath of that foot if it's not going to be in your shoe. We have some people that bodybuild, I don't know why you'd want to do this, but they do it without shoes, which is fine. Maybe they're trying to get a better feel for the ground or something like that. And I get that. But you just have to make sure that you're having something in there to help them to compensate just a little bit better. And then what's the degree of inversion that you have? You know, sometimes you get these real almost club feet or talipes type feet that are in, and they're just absolutely rigid, and you have to build them up. You know, with somebody that can actually, a podorthist that can actually build, you know, the insole of a shoe, or sometimes even a person that built shoes so that they can make it so that this person's going to be able to walk and be normal there.
I think something else to consider and not get tricked or confused by is sometimes you can have a forefoot varus with a plantar flex first, right? So that's kind of a little bit tricky, right? So you've got to account for the fact that the first is in that plantar flex position, can't extend beyond that neutral alignment. But meanwhile, the rest 2 through 5 is in that varus inverted position. So, you know, sometimes what I have done is I've kind of created almost like a little bit of a cutout on the medial side to allow the first MTP to sit, and then varus posted the 2 through 5 to kind of get them off that side some too. So give it all. It's like kicking the hole out of a tripod, right? Let the tripod sit down, but at the same time, make sure that you're aligning the foot properly as well.
Yeah, kind of like a first rate cutout, basically.
In essence, yeah. But just giving a little bit more of a canter to the 2 through 5, so it's not as flat. It's a little bit more gradual.
Well, and you're supporting them too. So when you're
Hmm.
supporting them, you're allowing that range of motion to not be quite so stark between the first and second metatarsal heads,
Correct.
which can
Correct.
create a lot of irritation in those tissues, sometimes even neuromas.
Correct. Awesome. All right. Third
So
and
look
last
at this
video
gal here
here.
with some limited dorsiflexion of her left great toe. It's post-surgical with a capsular in a position procedure. You can see she's got zero extension even when I press down on the first metatarsal head. She's close to about 5 degrees, surgical scar here. Flexion is almost 40 degrees, it's 38 degrees compared to the opposite side here. And again, I'm pushing up on the med here to try to facilitate that, just like I'm pushing down here to try to get a little more. So if I just pick it up by itself at 0, if I sink this head, I can get her to 5. If we look at the opposite side for comparison, you can see she's got the beginning of a hallux abductor valgus on this side as well. She does have 25 degrees extension on this side, and she's got about 40 degrees of plantar flexion. So we're looking at this gal here with some limited dorsiflexion.
Whoops.
Oops.
There we go.
Making a mess of the
There
audio
you go.
visual
Yeah.
here. There we
No,
go.
that's fine. Rigid hallux limitus. This particular gal had a bunionectomy with a capsular resection done, and they basically fused her. She's got minimal dorsiflexion. We really need 50 degrees to be able to move forward normally. And flexion is really kind of consequential. It's nice to have flexion, but we really don't need that to ambulate normally. This gal had very, very little. You'll notice that I was pushing down on the distal aspect of the metatarsal head. I was trying to recentrate that joint. So remember, when that head is down, you'll get a little more dorsiflex. You can try this on yourself. Plantar flex your first, dorsiflex your toe, dorsiflex the first, dorsiflex your toe, and you can feel the difference in the two. And that's moving that instantaneous axis of rotation I was talking about before. So it's certainly worth working on her soft tissues and things like that. But here's a gal that is going to probably need some sort of a Morton's toe extension and probably a rockered shoe, depending upon how she walks. Otherwise, for her to get forward, she's going to have to apiduct that foot and peel off toes 2 through 5, which may be a good compensation pattern for her, may not, depending upon what the rest of the anatomy looks like. Does she have, internal, external torsion, or what's going on? A rockered shoe will eliminate a lot of that need for the great toe dorsiflexion to actually occur, which will make it a whole lot easier for her. You have to be careful with your aggressive orthotics where you're going underneath the sus and you're really raising up the base of the first, because she can't dorsiflex at the distal first. So if we raise that up a lot, we're going to probably create pain for this individual. And this gal was coming in with pain, particularly at that articulation. So a big aggressive arch underneath the sus is not going to be a winner for this particular gal. A little bit more of a mellow arch, full contact, of course, with either a Morton's toe extension, carbon fiber plate with a Morton's toe, or a rockered shoe would certainly be better. Now, if you notice, when we went to the other side, she had pretty limited motion too. It just wasn't as limited as this one. So definitely working PT exercises and stuff like that. So things that are going to sink the first ray or move rays 2 through 5 dorsally with respect to the first ray are going to be appropriate.
Yeah, these are tough, and especially in the athletic population that I deal with, putting a Morton's extension on this type of patient is far from ideal, because you really put the gait mechanics at a significant disadvantage. The person's going to be very challenged with cutting and pivoting and quick type of movements because of that plate, and because now again, if they have pain and they can't do it, it's a way to kind of guard them. But in terms of their overall mechanics, it's tough, and that's why those athletes that have things such as turf toes can end careers, right? Because they don't have that mobility and they have a lot of pain through that joint. And it's really an important joint for lateral quickness and push off and acceleration, etc. So it's a tough one. And if you go into the rockered shoe variety, it's again, not all sports allow for or are built for a rocker type of situation. A lot of cleats aren't rocker bottomed and such. So it definitely is a challenge. And I think sometimes what I found, if you put a Morton's extension on those toes, sometimes, because the toe doesn't extend, it pushes down. Sometimes it irritates the sesamoids. I don't know if you've ever seen that, Ivo, but I see that quite a bit. And then to me, one of the most challenging things to deal with, and if you have a secret tool, I'd love to hear what it was. But if you have a secret treatment choice for a sesamoiditis or sesamoid pain, I'm always open to hear those because they are so challenging, and I dislike them very much.
Yeah, I mean, other than exercises which are going to work that extensor hallucis brevis, flexor hallucis brevis, and work on that relationship between the two, it really is tough. And then what you'll get a lot of times, depending upon the orientation of the forefoot, if it's the first ray itself will actually become inverted or everted. And when it does that, you'll get wear a lot of times along the articular cartilage on the osseous surface of the sesamoid where the cup is. We just had a patient in here that had a lateral sesamoidectomy. So it was the one, to the outside of his foot. He had his medial sesamoid specifically because of that and because of his gait mechanics. And he had degeneration and arthritis just in that one joint, which it was kind of wild. I'd never seen anything like that. I called my podorthist friend and we talked about the case for a while because he's the one that had sent him over, just about like, well, what caused it? I've seen bilateral, like I've seen crushed sesamoids and stuff like that, but I had never seen just unilateral arthritis just like that. But that can certainly create problems. And yeah, they are definitely a challenge. Again, if they don't respond well to exercise and things like that, activity modification. You can try that Morton's toe extension. If that doesn't work, then at that point they might be either looking at becoming a different sport athlete or discontinuing, what it is that they're doing. Not that you want to take people out of it, but just helping them to try to find a compensation around that.
I agree. Yeah. So again, hopefully you guys got a lot of little tidbits out of this. Again, we're going to have a lot more in-depth discussion and the ability to kind of play around with some cool tools and materials and really understand the ramifications of some of the adjustments that we're going to make to an orthoses. And you got to feel it for yourself sometimes and just get some hands-on experience and really deal with some of these common problems. And again, there's more than one way to deal with a lot of these things. I always say, and I believe that orthotic fabrication is more of an art than a science. There is science to it and understanding biomechanics, but what one person deems as really being a big culprit in a problem, another person may not view as quite as important, or may seem to think that another factor is playing a bigger role in it. And again, that's medicine, right? That's kind of what we do. But what we will do is we will give you, based on I know I have 25 years of experience, and I know Ivo's been doing this a long time too, both making orthotics, dealing with gait mechanics, walking and running, and we'll give you our tips and tricks as to what we find and have found to be the not the shortcut, but the way that seems to best deal with the problems at hand. So we look forward to seeing you guys October 5th and 6th in Dillon, Colorado. If you haven't registered and like to, we still have a couple of spots remaining at thegategeeks.com. You can sign up there. Whole lot of CEU hours for this hands-on lecture and lab-based continuing education course.
Yeah, can't emphasize enough that it's a lot of hands-on. It's a lot of like, we're going to show you how to do it, and then you're going to do it, as far as with posting and grinding and doing things. And then what we'll do a lot of times is we'll take your insole from your shoe or whatever, we're going to modify it, even if you don't need that modification, and we're going to make you walk on it so you know what that's supposed to feel like. And you can say, oh, right, I can feel the post pushing me from here to here, or wow, look at how it limits how this toe is moving. So that way you can actually see that, simple things like take one shoe off and walk on a treadmill, right? So now all of a sudden you have a pretty huge leg length discrepancy from side to side, and do that for 5 minutes so you can start to feel what muscles are really starting to come into play. So we really emphasize a lot of that. It's pretty low key out here in Colorado right now. It's beautiful. It's fall. The days are like 60 degrees, so it's really nice. We hope we get to come out and play. And we are going to be filming this as well. And we should have some information on that after the seminar is done.
Awesome. So again, from Ivo and myself, just wanted to say thank you for giving us your time. And again, hope to see you out in Dillon, Colorado in a couple of weeks. Take care, guys.
Thanks.